contractile lesion, you have a surface hemorrhages that occur on the opposite side of the brain of the trauma as a result of deceleration. And so, of course, that it's a whiplash type thing. The brain hits on one side, and then it whiplashes back and hits on the other side of the brain, and you have damage to the other side of the brain.
So can you have both?
You can have both, yeah. And you probably do, but. Okay, so secondary problems, what happens with head injuries is an increase in pressure inside there. So they have to get that pressure down, and they have a lot of drugs to do that now, which is good. Normal pressure is 10 millimeters of mercury. Pressure greater than 20 millimeters of mercury would be abnormal, and it will usually occur within the first week of injury, but can occur 3 to 4 months later. Head injury patients sometimes will just die, and it's because something's happened to cause that pressure to increase again. Signs are decreased responsiveness, impaired consciousness, severe headache, vomiting, irritability, palpal edema, which would be what? Swelling where? At papillary, yeah, in the eyes. And changes in vital signs. Anytime there's something going on with the eyes, like dilation of an eye, especially if it's just one or the other, it definitely makes a difference. So some of you actually probably had a little bit of training when you were with Kendall and they did the football stuff. Did some of y'all go to the football games and all that? So you'd had that training to recognize head injuries, right? I'm really so pleased that has become a big deal because it's hopefully it's going to save some kids from having some residuals for the rest of their lives.
How do they test intracranial pressure?
What now?
How do they test for intracranial pressure?
I do not know. I've never had it. That's a good question. Why don't you look at that? Okay. Anoxia injuries are when you have just a decrease in oxygen, and so if that happens to the brain, then it becomes pretty severe. But it is considered a head injury if someone has anoxia. Most frequently caused by cardiac arrest. The brain requires 20 to 25% of the oxygen supply. Most vulnerable areas, neurons in the hippocampus, the cerebellum, and the basal ganglia. What happens in the basal ganglia? The main thing I taught y'all? There's some other things I have to cover with.
The background.
Yeah, so it's that kind of, that motor function of posturing and that kind of stuff. Post-traumatic epilepsy with anoxia injuries is 5% of head injury patients will develop that. So almost across the board, they're going to put a head injury patient on some type of medication to stop seizures. So they're at least going to do it for a year if they have any kind of seizure activity at all. But sometimes they automatically do it before they even have a seizure. Okay. The Glasgow Coma Scale you just need to be aware of. The three things they look at is eye-opening, motor responses, and verbal responses. So kind of keep those three in your mind. It's on page 353 of your book. And if you have, what they do is when a head injury patient comes in to the ER, they give them a Glasgow Coma Scale. And there's a tremendous amount of research to show that that scale will represent how well they're going to do. With all the changes in trauma drugs, I'm not sure how much of this is even part of what they look at, although they always do Glasgow Coma Scales. If you have a head injury patient, they're going to do a Glasgow Coma Scale on them in the ER. That's one of the first things they do. So they look at eye-opening, motor responses, and verbal responses. And y'all make sure and look at page 353 because they give different numbers for, like if they open their eyes. Let me look at it.
You right.
It's not this book, it must
I
be
have
in the
to
other
use
one.
just I just did with extra stuff and add it into my PowerPoint. So I got you scribble and on the PowerPoint. I have it really sweet, so I have ADHD. Oh, we're so different. Like we both have anxiety and stress,
Yeah, you need to know where
but we
they.
deal with it differently. I know you procrastinate. Yours makes you productive and mine makes me put it off. It works better for you. Only sometimes.
It's on page 371 in the neuro book, and what they look at is,
What'd you say, 370?
if they have
371,
eye-opening, to spontaneous speech, if they just have spontaneous eye-opening and their eyes are just open, they get a 4. If they open their eyes when someone talks to them, they get a 3. If they open their eyes and because someone's putting pain, doing some type of pain response, they get a 2. And then if there's no response to any of this, it's a 1. Motor responses, no response is a 1. Decerebrate posturing, we're going to talk about that, and decorticate posturing is a 2 and a 3. Withdraws to pain is a 4. Localized means that they actually have some movement, localized movement, and then obeys verbal commands is a 6. And then on the verbal responses, if they're oriented, they get a 5. Conversation is confused, they're a 4, but they're talking. Use of inappropriate words is a 3. Incomprehensible sounds is a 2, and no response is a 1. So that's how that scores when they come in. They look at those 3 things, and that's the Glasgow Coma Scale. So if they have a 13 or higher, then they consider that a mild head injury. Loss of consciousness lasting less than 20 minutes and a normal CT scan. So that's good. 13 and higher is what we want. If you have a 9 to 12, you actually have a moderate TBI. The patient is unable to answer questions when arrived at the hospital, and they may have permanent damage. And then a 3 to an 8 would be a coma. Okay? And this again is done in the ER if they suspect a head injury patient. Some cognitive deficits, poor attention that you see with head injuries. You see, did anybody work with a head injury patient? The nice thing about head injury patients, again, is because of all the trauma care, you are seeing them come out of it so much better. We actually had a head injury patient here in the program about 8 years ago, and he is not working as a PTA, he's working in mental health, he's a counselor, but the main problem he had to deal with, that we had to come up with, is he could not remember what he did with the patient yesterday. So he had to write down every patient's name and specifically put down what he had done with them the day before. We had to really come up with some different types of things for him. He was in a car wreck, and the first time I saw him, because he was a student on campus when it happened, he was completely paralyzed in his left arm. He had 0 movement in the left arm. It was flaccid though, there was no spasticity. And then when I saw him about a year later, he had full movement in that arm. So probably what we saw with him the most is cognitive things. He was valedictorian of his class, which is what saved him. And so, but he probably really just struggled to make B's and C's in school and had a hard time getting through the PTA program, as you can imagine. So we did a lot of work with him to try and get him through. And but he's doing well. I see him occasionally live in Wilburton. But anyway, so you see that he's functioning well. And used to, it was just much more common to see them laying in a nursing home bed, completely spastic, all four extremities, unable to walk. Y'all seen, oh, and I'll tell you where you'll see some different types of severe head injury patients is when you see the veterans on TV, and they'll bring, show different, because they're trying to support the wounded warrior. That particular one has some head injury patients that you can see that are pretty severe. And so just kind of spend some time working with them. You deal with a lot more changes in personality and that kind of stuff with a head injury patient, I think. Poor attention span, disorientation, loss of memory, and ability to control emotional responses. They do sometimes have aphasia. Behavior deficits are neuroses, psychoses, sexual disinhibition. So if it's a male, females have to be aware of that. If it's a female, you have to be aware of that. Because female head injuries become very promiscuous. And so do males too. But what happens with a head injury male patient that comes on to a female? Pretty gross. Women think that's gross, and so it's not as a problem. What happens when you have a female who's 17 years old, who's never been promiscuous, and someone decides to take advantage of her because she's become promiscuous? Because she's a head injury patient. You think that happens? You bet it happens. You have to be very careful with your female head injuries, actually. Just to be aware of that. And to educate your family members. We don't have education for families like we used to about things like that. Apathy. Anytime you have an apathetic patient, it doesn't matter if they're a head injury patient, it doesn't matter if they're stroke, it doesn't matter what happens. If they're apathetic, you cannot get them to do rehab well. It's very difficult to fight apathy, and sometimes that's part of the brain damage. It's kind of affected that part of the brain where they don't have initiative to get better. And so that's hard.
What is apathy?
Pardon?
What is that?
Apathy. It's where they just can't, they don't have any drive to do rehab and get better. They can become very aggressive. They low frustration tolerance, violence. Sometimes they eat everything in sight. They have brain damage to the hypothalamus, and so you have to watch that kind of thing, and then personality changes. Motor deficits. They could have anything, because of the coop thing, they can have all quadriplegia, they can have hemiplegia, they may not have any effect in that part of their bodies at all. And they can have different levels of spasticity and placidity. There are two types of things that you see with brainstem stroke patients and head injury patients. And it's called decerebrate rigidity and decorticate rigidity. And what you remember, the way you remember it is decerebrate has two E's in it, and so everything's in extension. So the way that they present is they're in that extension synergy pattern in their legs. Their legs are into plantar flexion, and they're turned into internal rotation, like, Tuesday when you saw, what's that man's name? Michael has that extension synergy in that one leg. So you see that with the decerebrate rigidity, you see that, and then you see their hands and extension synergies here. So they're laying in the bed stiff as a board, like this, and this is what they look like. They do have flexion in their hands. So that's decerebrate. Decorticate is more severe, and they have the extension in the lower extremities, but up here their hands are like in the flexion synergy. They're like both of them are like this. Okay? So that's the difference, and the two E's will you have extension in upper and lower extremities. Decorticate, you have extension in the lower extremities, flexion in the upper extremities. And if you ever see that it's just not a good prognosis when you see those things. Any questions on that? Just terms you need to know, because you'll run into it somewhere. Common brainstem reflexes that we see. These are also baby reflexes. So as we get into doing pediatric reflexes next week, these are pretty much the same. It's just different when they happen in an adult. It's not good. Tonic labyrinthian reflexes, you put them in a prone position and it facilitates flexion. If you put them into a supine position, it facilitates extension. So you've seen babies do that. If you've been around babies at all, you'll put them, if you roll them over on their tummy, they kind of go into flexion. You put them back on their back, they go into extension. And it's almost like a tone with it. So that's called a tonic labyrinthian reflex. You might as well learn that now. Asymmetrical tonic neck reflex is where they do the fencing. So you turn their head towards that side. If you turn their head, this little arm will go out and this arm comes up into flexion. And if you turn their head the other way, then it'll do this. So that's AT&R.
One of the OTs at my clinical, she was doing a lot of testing on a lot of the kids for reflexes and stuff, so I got to see a
You got
bunch
to
of
see all that.
different ones.
Good. So that'll be good. You ought to do your in-service on that. On baby reflexes.
And a lot of them were like older kids too. What is it called whenever it doesn't go away?
It's just a residual. It's just there. It doesn't resolve.
Yeah.
Yeah, you don't want reflexes not to resolve at the right time. The symmetrical tonic neck reflex is flexion of the neck results in flexion of the arms and extension of the legs, and extension of the neck results in extension of the arms and flexion of the legs. So those are the three that you see sometimes with pretty severe head injury patients. Okay? And these are all baby reflexes too. But we don't want to see them in adults. We want them to resolve, right? We want them to go away when they're supposed to go away. Okay, here are just some more terms that you need to be aware of. These are also in stroke patients and head injury patients. There are associated reactions. When you think of an associated reaction, have you ever heard that term before? An associated reaction is you're going to do something to that patient or have them tighten up a muscle and they get a response from the other side. The most common one I always think about is if you have someone laying and they're in a bridge position and you resist the strong leg. If you'll resist the strong leg from coming in, the affected leg will start pulling in. That's an associated reaction. So you get a reaction by doing something to the body, okay? That's an associated reaction. Sequoia's phenomenon is flexion of the involved arm above 150 degrees facilitates extension and abduction of the fingers. And so what you see, this is more common in strokes, I've seen it in head injuries, is as you bring that arm up, they do this kind of a thing. So you get them up to about here, and that arm just kind of does this kind of a thing. And that's just a term you need to know. Do not run into it. Remiske's phenomenon is resistance is applied to hip abduction and adduction of the uninvolved lower extremity causes a similar response in the involved. So basically that's what I just talked to you about. So it's a way to, you resist the strong leg for adduction, and then the Remiske phenomenon is when that'll pull in. It facilitates that to work. Or you put the hand on the outside and have them push against you on the strong leg, and the other one you'll feel tension start to develop in the affected leg. Okay, so those are associated reactions. Those are two names you need to know. The homolateral limbs synkinesis is flexion of the involved upper extremity, involved flexion of the involved lower extremity. So what happens is, and where you see this is in gait training, if that arm starts to come up, and I don't know if you'll notice with Michael, but when he walks, his arm starts to kind of come in a little bit into flexion. So, that happens because they're working with the leg. So that's just a reaction where the arm and the leg kind of go into spasm together, okay? Spinal reflexes, these are some that you're also going to see with kids. Flexor withdrawal, cross extension, startle and grasp. And don't worry about these for head injuries because we're going to go over these a lot with the pediatrics. So we'll cover those even next week. Okay. Here we go. We got 3 more. Okay, heterotopic ossification. Have y'all heard of this term? Okay, where did you hear it? With what?
Kendall's class.
Kendall's class, and what happens?
That's where bone forms when open muscle or repeated trauma.
Right, so you have a repeated trauma to it, usually it's a biceps, isn't it? And it kind of calcifies in that muscle, and it develops almost like stone in there. That is a real common thing with contractures for head injury patients and for probably spinal cord injuries more. And it happens at the knees and the hips. The hips are probably the most common place. And basically it's because they don't get enough, I don't think they're sitting up enough. But if they lay in bed for a long time, then this ossification can come, and it literally has to be surgically broken up so that they can get range of motion in their hip again. So where y'all see it in an orthopedic patient, normally it's in the biceps, and it can happen in the quadriceps too, I believe. You can also see this with your head injury patients and your strokes, but more so with head injuries. It occurs in 11 to 76% of TBIs with contractures. Common joints are hips, knees, shoulders, and elbows, but the most common is the hip, okay? Ranchos Los Amigos. These page numbers go with your rehab book that y'all got. If anybody brought their book with them, it's not this neuro book. The Ranchos Los Amigos, does anybody know where Ranchos Los Amigos is? Or even what that is?
California hospital.
Yeah, it's a California hospital in Los Angeles, and there was tons of research done for head injury patients and spinal cord injuries. It used to be a major spinal cord and head injury centers even when I first got out of PT school. I have no idea if they're still doing this or not. But anyway, a lot of research got done there, and that's where the Ranchos Los anything comes from. So Ranchos Los Amigos scale for cognitive function. On the different levels, it goes all the way up to 12, I believe now. But 1 is no response, 2 generalized response. And if you'll go into your book and read through these, I don't think you don't need to memorize them. I'm not going to test you on them, but you just need to be aware. What happens when you get a head injury patient in rehab, or used to, you would have a Glasgow-Coma scale of 5, and you will have a Los Ranchos Los Amigos functional scale. So when they come to see you, or when they'll tell you that the scale they're at a level 6. So that gives you an idea of kind of where they're at. And that's what the purpose is. You want them to get all the way up to level 10, purposeful, appropriate, modified, independent. So these are just the different levels that they are, but if you'll go back into your book and read that, that will be good to look at that.
Is this the right rehab book?
Yes.
I don't think that page matched up.
That isn't where is the Ranchos Los Amigos?
I don't know, 358 is cardio poem. And it's like the end of a chapter, it just has definitions.
336 is the last
It's on those folders.
It should, I'm pretty sure it's in there, so just look it up.
Oh, that's for cycle.
And it probably's in the neuro book too, actually,
Yeah.
in the head injury.
It's in the score builders book, that page on the Rancho Salsa, did you guys see?
Yeah,
I
right.
didn't bring that book. Oh, yeah, wait.
This one is,
It's
Yeah.
336, Ms. Hovey.
336, okay.
336, well, 336 to 337.
In the one you're in,
Yeah,
okay.
the Glasgow coma is on 336, and that thing you just had on there, the last slide is on 337.
Okay. Let's go take a 5-minute break and head to the lab, and we're gonna do the trunk,